Quality Watch is an educational production of IPRO. Opinions expressed reflect the views of the speakers only and not those of any company or agency. This podcast is intended for private, non-commercial use only. Please visit ipro.org to read our full disclaimer and terms and conditions.
Welcome to Quality Watch, the podcast focused on healthcare quality improvement. Quality Watch is a production of IPRO, a trusted partner of federal and state agencies working to measure and improve the quality of healthcare for all. I'm your host, Dr. Edison Machado, Senior Vice President of Strategy Solutions here at IPRO. In today's episode, we'll cover the potential rise of health misinformation on social media, the federal government's push to make it easier for entities to share health data, and much more. But first, a few quick headlines and updates from around the nation and here at IPRO. The Commission on Clinical Obesity has proposed changes to the way obesity is defined. Rather than a simple measure of body mass index or BMI, the Commission suggests adding measures such as waist circumference and the presence of symptoms of reduced organ function. The Commission believes that this more nuanced approach will enable evidence-based approaches to prevention, management, and treatment of obesity in adults and children. You can find more details on the Commission's recommendations in an article published in The Lancet Diabetes and Endocrinology in January. Meta, the company that owns social media platforms Facebook and Instagram, recently announced that it would end its use of fact checkers to flag misinformation and disinformation published by users on its sites. Instead, the platform will rely on a user-based community note system to identify inaccurate or misleading posts. Some public health experts are concerned that this move could increase misinformation about science and health that is spread via social media, potentially impacting public health. And in January, the nation laid to rest former President Jimmy Carter. Many paid tribute to his public health work, including efforts to eradicate guinea worm disease, a crippling parasitic disease transmitted in areas where people drink contaminated water, as well as river blindness, a parasitic worm that primarily affects people living in African countries, parts of Latin America, and Yemen. In late 2023, the Trusted Framework and Common Agreement was established as a nationwide policy and technology framework for health information sharing. TEFCA was created by the U.S. Health and Human Services Department to remove barriers to information sharing among providers, patients, public health agencies, health information networks, payers, and pharmacies. The goals are to improve the flow of data to improve patient care, public health, benefits determination, utilization review, quality assessment, quality improvement, and much more. Joining us to discuss TEFCA today and its promise for patients, providers, and public health agencies is Matthew Roberts, IPRO's Chief Technology Officer. Welcome, Matt. Glad to have you join us today.
Hello, Dr. Machado. Good to be here.
Great, Matt. Well, let's jump right into it. Health interoperability first hit the national radar in 2004, and that led to the creation of the Office of the National Coordinator. So here we are 20 plus years later. What sets TEFCA apart from previous initiatives designed to advance the exchange of healthcare data?
Excellent question. And I think to begin with an answer, it helps to have a little bit of a history lesson, as you've already alluded to what happened 20 years ago and since, and how TEFCA sets apart from the past. So as you noted, before the creation of the ONC, the Office of National Coordinator for Health IT, there was no coordinating entity whatsoever for the U.S. healthcare system's data and the interoperability of that data. It was, I'm not going to say the Wild West, but it was completely ungoverned, everybody doing their own thing. And over the course of 20 years, that healthcare data has transformed immensely. And one of the biggest shifts in the past 20 years was the use of meaningful use money and legislation and the like that invested billions and billions of dollars into healthcare IT systems to strengthen that healthcare data. Before meaningful use, there was a vast swath of the country that didn't even have hospitals, that didn't even have electronic health record systems, mostly paper-based systems for doing their medical care. As you can imagine, it's very laborious, very manual, hard to share stacks of paper from one doctor to the next. So this was a vast improvement, but what was still has been lacking for meaningful use till today has been the sharing of that information from one doctor to the next, one hospital to the next. It didn't matter if that hospital, that practice was across the street or across the country. The fax machine or whatever it might be was always the easiest way to send that information. And without it being structured and set up with the right standards, which I'll talk about later on in the program, has just not lived up to the entire promise that everyone hoped that it would. TEFCA is designed to improve that interoperability and the exchange and flow of data across the entire U.S. healthcare system.
Great. Thanks, Matt. That's really helpful in terms of just trying to set the stage here. So if you wouldn't mind, would you mind just giving us a basic primer on exactly what TEFCA is and maybe who are some of the key players at the table with it?
Absolutely. So if I take a zoomed out look or at the 30,000 foot level, TEFCA really is everybody in the U.S., but patients, doctors, and hospitals. And so we're all part of TEFCA in some ways, but more operationally, more concretely on a day-to-day basis. What we're talking about are the participants of TEFCA, including doctors' offices, hospitals, that might be participating through X, Y, and Z channel, which I'll explain. It's also the insurance companies. And by part of all of that, it's the patient. The patient is included in this interoperability. Now, very concretely, what this comes down to is there are a few entities and groups that we'll talk about here in a minute that are organizing and coordinating all this data exchange, especially putting privacy and security at the forefront, making sure that all of this data exchange is happening in accordance with federal and state laws and regulations. But going with a new set of standards that vastly improve upon prior versions of the standards that improves the interoperability of the data. And we'll talk about FHIR, I know later on. I'll get deeper into that and how it interrelates. But the main folks that are really pushing all this forward for TEFCA include state health and information exchanges, the Sequoia project, which I know we'll talk about soon as well, QHINs, and also these other groups that are part of the entire riddle, such as ourselves. We play a role too. Anybody that has any stake in healthcare data and being able to use it for direct patient care delivery, which is first and foremost, but for any other purpose, such as quality improvement, like IPRO. This is where we all play a part in helping make sure that TEFCA works.
Okay. Well, speaking of which, why don't we jump into sort of deciphering some of the roles that some of these players play. So I think you alluded to the Sequoia project, and the Sequoia project is the recognized coordinating entity, or RCE, for TEFCA. Can you explain a little bit of what that role entails?
Absolutely. Think of the Sequoia project as really more or less the quarterback, the QB for this entire initiative. So you mentioned, we've talked about ONC, which is now just over the past summer been relabeled, rebranded, and repurposed as the Assistant Secretary for Technology Policy, or ASTP. The federal government, ASTP, at the U.S. Department of Health and Human Services, knew that in order to be as nimble as they wanted to be with this effort, they needed to have some groups kind of helping run quarterback on their behalf. And that's exactly what the Sequoia project is doing. They are spearheading and organizing and coordinating the advancement of this entire initiative, everything from project management to just making sure everything flows, the nuts and bolts of the entire initiative as smoothly as it can. So they convene, they bring everybody together. They also play a major role in helping make sure that the entities that are involved in part of this data exchange, the QHINs, that they are the right types of entities that are meeting the right sort of standards, ensuring privacy and security are met, all those things that we would expect out of robust national healthcare data exchange.
Got it. Well, it sounds like the Sequoia project group plays a critical role to the ongoing implementation and success of the effort. You touched upon a new phrase, probably for a lot of folks, QHINs, or Qualified Health Information Networks. Can you elaborate a little bit on what those entities are and maybe what they do?
Absolutely. So just a few examples. And I tell folks that are completely new to all of TEFCA and everything, you can either Google or put in your favorite search browser of choice. I don't have any of my own, but you put in your search, just search for TEFCA and QHIN, and you'll get a nice listing of who these groups are, and anybody can look them up. But a few examples: eHealth Exchange, the Commonwealth Alliance, Epic.
Some examples of QHINs.
There's some of that have been certified. They're part of the process. They're approved as part of the QHIN actors that are part of this exchange. So what that means is Sequoia has worked with them and with ASTP to say that these groups are allowed to be part of this network of approved vendors and entities that are sharing this data. And one of the ways you can think about who these groups that I just mentioned are, think of them as in some way kind of similar to the major cell phone carriers.
Mm.
So in many ways, they're competitors, right? They kind of compete with one another, just like AT&T and Verizon, right? So their role is to share a phone message or share text messages, information across one person to the next, and different customers, different providers, hospitals can pick whomever they want to be part of. Different statewide HIEs, such as the Connecticut HIE, for instance, could join any of these different QHINs. But the thing that binds them together, despite them being quote unquote competitors, is that they're all agreeing to go and use the same rules, the same structures, the same onboarding agreements. We're all part of the same legislation. It's all part of a same and consistent package that everybody's playing in the exact same sandbox the same way. They may have different techniques for the way that they interoperate and the like and what they kind of use. But for the most part, this is the entire idea, is that they are all going to work well together and interoperate seamlessly together.
Got it. Thanks, man. I mean, and I appreciate how you're drawing parallels to things that folks are more accustomed to and comfortable with to sort of get a better understanding of, these players that many folks and many of our listeners may not have heard about before. So the Sequoia project, as of a few months ago, listed 10,000 entries on the RCE directory. And this included, 7 QHINs, a number, 100 plus participants, and, a ton of other sub-participants. How large are we looking at TEFCA becoming, essentially?
It's an excellent question. And, I don't have a crystal ball.
Sure,
if I were
sure.
to guess, considerably. Now, will we go from 7 QHINs to 27 or 107? I don't know. That probably remains to be seen. Mm-hmm. But I expect that over time, if TEFCA lives up to its promise, which that's a big caveat because we've had many fits and starts with this whole interoperability campaign over the course of, as you noted, over 20 years, really. But if it lives up to its promise, then I think a lot of people will join on the bandwagon. Mm. One big point, and HHS and ASTP made a very big point of this public release. What happened was, I believe it was just last year, I mentioned Epic Nexus joined. Mm. So I refer to meaningful use in the electronic health record system.
Sure.
Right? Epic, and there's also other EHR vendors out there, electronic health record vendors, but Epic, such as Cerner, Allscripts, these are just a few.
These are the big EHR players. Sure.
Vendors. Epic, from a way of looking at their market share, is one of the bigger players. Mm-hmm. They have a lot of private practices and doctors' offices and hospitals and the like, all using their system. And just because Epic has joined, which is quite significant, mm-hmm. that they joined up, that already means that a lot of practices and hospitals that are already using Epic are able to interoperate that much more seamlessly within Epic, but also with the other groups that are also part of the QHIN networks. So just by Epic being on board sends a very, very, very strong signal to the entire healthcare industry to say that it's time for interoperability to be here. Now, where this goes from here, I think remains to be seen. But I think it certainly is hopeful for the promise of what is to come in terms of interoperability and data exchange.
So it sounds like via these existing players that are already at the table, you're really looking at, a much larger pool of interested parties or stakeholders sort of already being at the table, vis-a-vis. So that's quite interesting. Speaking of which, with regards to IPRO, so is IPRO in any way a member of TEFCA or connected? And if not, is it expected to become so?
We are not yet today, but at Magic Wand, we would be. We would just be in TEFCA and we'd be right there. I think that it makes a lot of sense for us to be participating in this entire movement, whether it's expressly through TEFCA or other groups that are becoming parts of any given QHIN, which puts us into play with the TEFCA movement, but also more generally with standards development, including FHIR, which again, we'll talk about in just a moment. But as I mentioned, so one of the main reasons why this is important is that it probably helps with direct patient care. The doctor is sharing information with one doctor to the next, right? One hospital to the next. Super important to make sure that patients are getting the care that they need at the point of care at the right time, right information at the right time.
Sure.
But there's so many other meaningful uses of healthcare data in the entire industry, such as the quality work that we do. We are steeped in healthcare data, even at IPRO. But if it's, as an example, if it's claims data, that data is usually outdated by months, at least months, right? Now, as we all know, with the broader internet, information travels at the speed of light. It can be shared very quickly, right?
Sure,
but why not our healthcare data? Claims data is going to have a lag. Clinical data that's coming straight from those electronic health record systems, you don't have to wait 60 days for that. It's going to happen much more quickly. And as long as it's more complete and adhering to the structures and standards that I've been talking about, such as FHIR, then we can count on it being way more actionable, way more timely, and for us, more useful because of its richness in ways that claims data may not be able to provide the detail. I'll just use one example for sepsis, for instance. If we were able to be part of TEFCA and get clinical sepsis information from across the entire country, we could take that information in almost real time, reduce it down to a certain quality measure or some sort of metric, provide that information back to that provider, that doctor's office, that hospital, or even perhaps to that state health department in a much more timely fashion in ways that you wouldn't necessarily get out of just a claim of the medical billing side.
Sure.
Because claims are a little bit slower and they're geared towards a different purpose. But if we do, for instance, respiratory rates at a certain interval, which we get measured in seconds instead of months, it changes the entire dynamic. And for IPRO, that's a big part of what we're trying to do and what we want to do in general as far as healthcare data exchange.
Great. Yeah, no, and funny enough, I think you sort of went ahead and answered the next question I was going to tee up, which is, how exactly do you see TEFCA being of assistance to IPRO in carrying out its work? And I think the example you just laid out with regards to the sepsis project, really makes it pretty concrete, right, and real as to how that involvement and benefit from that better data exchange could help improve the work we perform for our clients. So that's really good to hear.
And that's just one example. There are hundreds, dozens, if not hundreds, as we can say, across the entire industry.
Sure. So you've touched upon this a few times, this phrase FHIR, which stands for Fast Healthcare Interoperability Resources. I think FHIR sort of sounds better when you actually say that whole thing. Do you want to talk a little bit about FHIR maybe and its connection to TEFCA and so forth?
Absolutely. So FHIR, Fast Healthcare Interoperability Resources.
That's a mouthful.
It's a mouthful. FHIR is easier. It is the latest and best, in my opinion, version of the HL7 standard, Health Level 7 international standard for healthcare data.
Okay.
There are prior versions such as called V2 and the CCD, CDA. I won't go into detail about
more acronyms.
What's been great about FHIR, which is roughly about 10 years old at this point. It's been in place for about a decade. A couple of things that makes FHIR great and also stand out against the prior versions of the standard and how it relates with TEFCA. Mm-hmm. A couple key pieces is that the prior versions were kind of idiosyncratic or specific to healthcare. And what I mean by that is that you really had to be an expert in healthcare, which is complicated.
Sure.
In data, which is complicated. And in order to be in that sweet spot, that intersection between the two, you had to be completely, very, very specialized in HL7v2 CCD-CDA, very, very tied and wed to two very complicated industries coming together to help make sure that data interoperability and data structure and common data models for data sharing were all set up the right way. It's a huge barrier to entry. One big change between FHIR and the prior versions is that it's based upon broader web standards that are not just specific to healthcare, but across the entire web, such as JSON and XML, APIs, OAuth security protocols. This is not just unique to healthcare. This is every part of the internet is using some of these concepts.
Got it.
But now healthcare is running on the broader constructs of the entire World Wide Web. It's still maintaining the privacy and security that we need. In many ways, you can say it's bolstered because it's not a specific healthcare use case, but it's using technologies that are used across the entire internet. That changes the entire scene in terms of how the U.S. healthcare system can participate in the ways that every other industry has been able to use the internet.
And maybe piggyback on their innovations and advancements.
App development to that effect, the innovations that go on every day, tiny security here, all of that. So everything that is enabling is helping improve the way that healthcare data is structured and shared from one hospital, one practice, one EHR vendor to the next. And what TEFCA does is it taps directly into FHIR, especially with the APIs, stipulating if you're going to be part of TEFCA, then you're going to use FHIR. You're going to use all of these standards. This is baked in right out of the gates, right at the start. All of these QHINs that I talked about, they are all using the exact set of common, modern web standards that I just talked about. Again, it's not just for healthcare, it's for the entire web. But enabling this in healthcare today, in the U.S. healthcare system and abroad, changes the entire dynamic. And they're all playing by the same set of rules.
Well, Matt, you've covered quite a bit with me over the past, few minutes here. And I'm sure we could continue the conversation for another hour or so, but I know you're a busy guy. And so I just want to take this opportunity to thank you really for taking the time out of your busy day to join us and join our listeners and give them some insight into TEFCA and the alphabet soup that goes along with it. But more importantly, how it could be of support to organizations like an IPRO and others in the healthcare field. And, it sounds very promising, I would say.
Absolutely. Fingers crossed. My pleasure. Thank you, Eddie, for having me on today.
All right. Thank you. Ed, for more information regarding TEFCA and IPRO's involvement, feel free to visit our website at www.ipro.org or www.ipro.org. It's time for us to crunch some numbers in our Data Watch portion of the program. The HIPAA Journal reports that the number of healthcare data breaches has shown an upward trend over the past 14 years. In 2023, 725 data breaches were reported to the HHS Office for Civil Rights, with more than 133 million records affected. The number of people under the age of 65 who were uninsured held steady at 25.3 million in 2023, according to KFF Health News. However, the number of uninsured children grew from 3.8 million in 2022 to 4 million. And finally, Fierce Healthcare reports that Epic has made it easier for patients to share medical records data with mobile health apps. This move is part of the TEFCA initiative, which we just discussed with Matt Roberts, IPRO's Chief Technology Officer. That's it for this episode of Quality Watch. I'm Dr. Edison Machado, and on behalf of IPRO, I want to thank you for listening. To learn more, visit our website at ipro.org. That's IPRO.org. And if you enjoyed this podcast, which I hope you did, please leave us a comment and subscribe wherever you listen to podcasts. We will be back next month with more. Until then, we'll be working on better healthcare realized.